Hello everyone, and welcome to Pharmacodynamics. How is physiology going? I hear your teacher is the worst. Just kidding. All right, so this is pharmacodynamics. This is going to be your intro to all things pharm. Obviously, me being a pharmacist, I am a pharm nerd. My job is to get the stuff I learned in pharm school. Keep in mind, I was in it for 4 years. Try to condense it down in over the next year or so. All the really critical stuff you guys need to know about prescribing drugs to people, right? Because if you're going to screw up and hurt someone or kill someone, it's probably going to be with a medication. Not to scare you, but it's very, very important to you take this not too lightly and realize that and almost everyone gets a medication prescribed to them, right? Like if you go to the doctor and they don't give you any prescriptions, like you feel like you're gypped, right? So you see a lot of overprescribing, right? And so I'm going to try to go over cases where it's appropriate to do so, and cases where you probably shouldn't prescribe medications. That's just as important to know who not to give them to. And so this is a lot of intro into the fundamentals for understanding all the stuff that comes about in Pharm 1 and Pharm 2. So what did you hear about pharmacology from like people coming who are already in PA school?
It's one of the hardest.
One of the hardest, yeah, absolutely. I try to make it as easy as I can, but in the end, it's like learning a new language, right? Hearing things like, hydrochlorothiazide, things like linazolid or levetiracetam. Like you guys are going to be able to look at these words that look like complete gobbledygook and be able to understand, like, okay, that's a cephalosporin. That's an antibiotic that I use to treat these type of infections. I'm going to try to work you guys through and understanding like how you can look at a drug name and decide like, okay, this is the type of drug I want to use for this type of patient to treat this type of disease state, right? And so there's a lot of steps between there. Understanding things like mechanism of action, how that's basically how the drugs are going to work. We're going to talk about side effects. We'll talk about contraindications. And that's all Pharm 1 and Pharm 2. But here we're going to look at the fundamentals of how you can at least understand that information when it's trying to learn all these different things. Okay. It is very hard. This class is not super hard. I will say that much. There's only one test associated with it. I already see some people had freaked out about that, but it's not a very hard test. It's really conceptual based, and we're going to do a review beforehand, so you guys will be able to see what type of questions are going to be on the test itself. Again, it's only one credit hour, so we only have 8 lectures or so when we're doing this. Okay. So, again, it'll be 150 question test, 75 or better to pass. I've never had to do a remediation for this class. If that gives you any kind of solace, never had anyone fail one of these tests. Okay. Clinical pharmacology, pharmacology 1 and 2. That's another story. Those are hard. Okay. There's no way getting around that. But I'll try to get you guys as prepared as I can for that. Okay. Yes, ma'am.
Just for drug names, are we going to do like brand and generic, or is there something?
Yeah, so we won't get too terribly deep into drug names here for this class, but when I do that, I'll always put brand and generic. Some people will only learn drugs by their brand name, which is not good practice. Like you should always really be able to recognize the generic name of a drug, but it's anything to help you guys out to try to be able to identify these drugs and answer questions about them, right? This also leads into the clinical pharmacology course, which you guys will do this time next year. Professor Quinones does that class. It's going to be much more kind of rubber hits the road, like here's your disease state, like what prescription do you write for this patient, right? So we'll get the fundamentals in pharmacology 1 and 2 about what the drugs are, how you use them, and then it'll be like strictly like who are going to use it in this type of patient, that kind of thing. So we can kind of see we'll kind of keep building on that knowledge as we go forward as we're talking about these different drugs. Okay. Hands are for you guys so far. We're sufficiently freaked out. Don't be. This class is not going to be that bad. So here's some things we're going to be talking about. First off, we're going to be talking about some of the pharm terminology they'll be using pretty frequently throughout the course. Routes of administration, how you get drugs into the body, and then we'll also talk about receptor theory as well. We've alluded to some of that in the physio courses, but we're going to talk about much more in detail on how the signaling actually occurs during that process. Next, we'll talk about secondary messenger systems, how when a drug binds to a receptor on the cell surface, what are the downstream effects that occur to have drug effect actually happen, okay? Talk about those, talk about dose-response relations, talking about, if I give you this much drug, what should I expect to happen? And how does that compare against other people? Or, what effect should I expect? If I give, what's the difference between a lethal dose 50 and an effective dose 50? Probably don't want to give it a lethal dose 50, right? We'll talk about how to stay away from those, right? We'll talk about bioavailability, which is how much drug, when we give a drug, how much of it actually gets into the system, and bioequivalence, or how they compare different drugs to one another. And then we'll talk about special populations. Obviously, who do you think the primary type of patient population you're going to be dealing with when you get out there in the real world? Probably geriatrics, right? So they have a lot of medications they're going to be on, and so it's really, really important to understand why they're kind of an at-risk group based on their physiology and based on the number of medications they have, but also neonatal pharmacology and how that is also another group who's very susceptible to the effects of medications and how we can have some safe practices there. We'll talk about therapeutic drug monitoring as well, which is basically going to be measuring blood levels of a drug and determining how we can change our dose or our frequency in order to achieve maximal therapeutic effects. Okay, you'll see if you go and work in a hospital or if on your own rotations, you'll see that in a lot of cases pharmacists do this, where if a patient is on a specific antibiotic, we will actually be measuring blood levels to determine, okay, here's how you should change your dose to this, and that. We'll talk about some of the rationale for why we do that and what drugs we do that in. And then we'll talk about how we design dosage regimens, and then we'll have an exam review, and then you'll have the test, and then you guys will be done. Yeah, pretty straightforward. So again, this is kind of like your traveler's dictionary. This is like kind of the intro stuff, the fundamentals for how you can understand when I say gobbledygook, like chlorthalidone or metolazone, like you need to be able to differentiate between those drugs. You'll have a better understanding of how to do that, right? Okay, so anyway, so we'll talk about the objectives here today, really just talking about terminology and routes of administration. We'll also talk about our receptor theory as well. Okay, we'll go through all these right now. You can read those on prefer. Otherwise, we'll just get to them when we talk about it in the lecture. So again, we mentioned these today. First off, let's do our definitions. Okay, drug names. How do drug names come? Your classmates already mentioned it. Trade name, right? That's our brand name. It's a proprietary name for a drug. What's an example of a brand name? Tylenol, Crestor, Advil. Any other ones? Dilantin, yeah, that's a good one. Yep. Yeah, so you guys already know some brand names, right? You guys are already pretty well versed in this stuff. You guys are experts. Then we also have the generic name. So this is going to be the actual, the public non-proprietary name that will come for a drug. And so this is what's approved by the FDA, which is the Food and Drug Administration. They're the ones in the government that has all the kind of purview over medications, right? Also food and also cosmetics, but mainly we're focused on them for the D part. So, for example, the generic name for Motrin is going to be good. How about for Tylenol? Acetaminophen. Yeah, I had one guy come up to the counter one time and he said, "I need my acetaminophen." What? It took me 10 minutes to figure out what the heck he was talking about. Yeah, there's some weird patients will have some odd pronunciations. Wouldn't laugh. Yeah, wait till you guys are actually having to pronounce the names yourselves, and then you'll also find that you have a tough time. Harder than it looks. So anyway, so then once we have our generic names and our brand names, right? And so obviously generics are going to be the more common way for us to refer to them, but many drugs still get called by their brand name pretty commonly. So we'll kind of run into some examples of those. We'll talk about the pharmacotherapeutic classification. So it's kind of what category of drug that they fall into. So for instance, ibuprofen falls into the category of a non-steroidal anti-inflammatory drug, or an NSAID. We use a lot of acronyms to try to help differentiate these drug categories, but this would be an NSAID. Helps as you can tell, it's a non-steroid, and it's an anti-inflammatory drug. So sometimes the drug classifications are useful to helping you know how the drug works, right? We'll talk about the mechanism of action, or the MOA. This is basically how the drug actually does its therapeutic effect and also possibly its toxic effects. But in this case, for an NSAID, it actually works by inhibiting an enzyme called cyclooxygenase. When we were talking about prostaglandins, this is one of those cases where these drugs are inhibiting an enzyme responsible for producing prostaglandins. So by inhibiting that, you can inhibit inflammation. Okay, and then we'll talk about indications. So how do we use the drug? What disease states is this going to be indicated for? So usually we'll use it as an anti-inflammatory drug. So you might use it for inflammatory conditions like rheumatoid arthritis, right? Or you may use it as an analgesic. So if you sprain your ankle, someone may tell you to take ibuprofen. And also use it as an antipyretic. What does that do? It reduces fever. So this is a very common drug we give to help reduce fever in those patients. Now, when you say like an off-label indication, what do you think that means? Okay, so maybe not a usual use. Yep. So usually when a drug is brought to market and it gets approved by the FDA, it has a list of approved indications, right? So some drugs will have approved indications for treating hypertension or treating diabetes. Sometimes you'll find that drugs are used for other things that are off-label use. Now, is that legal to use them for off-label use? Yeah, you can, absolutely. So now, for instance, you wouldn't want to use like an antihypertensive drug to treat diabetes because that doesn't make any sense. But in a lot of cases, there's clinical evidence to support use of drugs for off-label uses, and it's okay. So as long as you can show, say, for instance, someone tried to sue you for using a drug inappropriately, you can say, well, listen, I have all this clinical evidence behind me saying that they've done it in this many thousand patients. They use it for this, and it's very effective. And they say, okay, you're good to go, right? So it's kind of those things where off-label use is still okay, and in a lot of references, they'll still kind of talk about what off-label uses you can use a drug for. But that just goes back to what the FDA says, hey, this is approved or not approved for. And sometimes drugs can go back, companies can bring drugs back to the FDA and say, hey, we would like to get new indications for this off-label use, and they can add it to that list. Okay. So when we talk about pharmacology specifically, this is going to be that study of the reaction of drugs in the body, and also include reactions between drugs as well, right? So drug-drug interactions are very important to take note of when you're prescribing things to patients. Because again, for those geriatric patients, do you think they're on like one drug, or do you think they're on like a lot? Like 15 drugs in some cases. Like, you guys ever heard of a brown bag event? Right, we go to the nursing home and have them bring out their brown bag that has all their medications in it, and they're like 20 bottles of stuff. Like 5 of them they've not prescribed anymore. One of them's from like the 60s, and yeah, so those type of things. So drug-drug interactions are super, super important because that can be really, really dangerous for people. And so pharmacology is this kind of umbrella where we have pharmacodynamics and then pharmacokinetics. So kind of two sides of a coin of how these drugs are working. Specifically, pharmacodynamics is going to be how the drug affects the body. Okay, so this is going to be the study of the mechanism of action and how it actually comes about, has its therapeutic effect. Also, possibly, adverse drug reactions and toxic effects. And again, everything can potentially be toxic. Like, is there any drug that has no side effects? No, every single drug has side effects. So if you think about it, anything can be a poison. Even water can be a poison, right? How can water kill someone? Drink too much, and what does that cause? Water toxicity. It actually causes hyponatremia. Actually dilute out all the sodium in your bloodstream and cause seizures and death, right? You guys remember when the Nintendo Wii came out several years ago? There's a radio contest where it was called Hold Your Wii for a Wii. And they had people drink a ton of water and see who could hold their urine longest. And whoever won, unfortunately, she ended up dying from this hyponatremia and developed seizures, right? So actually, I believe got sued over that, and all kinds of bad things happened. But so again, anything can be poisonous given the right dose, right? Even oxygen can be poisonous if you have too much of it. So a good example of the pharmacodynamics of everyone's favorite substance, or maybe some people's favorite substance, ethanol, right? Who's ever imbibed any alcohol at all? Anyone? No one's raising their hand. You guys are all way too straight-laced. You guys have been in PA school. I'm not going to do any of that stuff. Some of you probably aren't even 21 yet, you youngins. Yeah, so anyway, so looking at the clinical effects of ethanol, you've probably at least seen someone who's used alcohol. At low dose, you can see it acting as kind of a social lubricant, right? So you have like one drink, and all of a sudden, like, I have relaxed inhibitions. I can go ask that girl out. I can do all sorts of things. As you start to get to higher doses, say more moderate doses, where you start to see slurring of speech and coordination. They're stumbling around. And then finally, at the very high doses, where you see them passed out. They have respiratory depression. You potentially die from that, right? So all of that has to relate back to the dose of alcohol in the body and how that's affecting the receptors and affecting different organ systems, right? So that's all pharmacodynamics, the effects of the drug on the body. On the flip side, you can have pharmacokinetics, which is the way that the body affects the drug. Okay, so this is usually a relationship between the concentration of drug versus time, how the body is absorbing the drug, how it is distributing it, how it metabolizes that drug or breaks it down, and then how it will excrete or eliminate the drug. Okay, so this is all the factors of pharmacokinetics and how the body's handling that drug and how it wants to get rid of it eventually. Going back to ethanol, if you imagine something like an alcohol-naive patient, so apparently all of you guys are alcohol-naive. If I were to give you a drink, your liver enzymes would be responsible for metabolizing that, and you would do it at roughly a rate of 20 milligrams per deciliter per hour. Okay, because that's, your baseline liver enzymes are not used to metabolizing alcohol. They can only do it so fast. And so you say, okay, about every hour you're going to be able to metabolize about 20 milligrams per deciliter. On the other hand, though, when you have chronic drinkers who have been drinking a lot every single day, those enzymes, they start to ramp up and they try to become more prominent because of the fact that the body doesn't like ethanol around. It wants to get rid of it. So by ramping up those enzymes, they can actually metabolize alcohol a whole lot faster. They may be able to do, say, 60 to 80 milligrams per deciliter per hour. Okay, and so it would take a whole lot more alcohol for them to get drunk for those pharmacodynamics because they're just getting rid of it so quickly. Okay, so those kinetics can change based on the type of patient, based on drug interactions, all kinds of different things there. So again, pharmacokinetics, the effects that the body is having on the drug itself. As you can see here, after a drug is being administered, after we give a dose of drug, whatever route, and we'll talk about different routes of administration, how we get drugs into the body, it'll have an absorption phase, right? And so we'll have a certain percentage of drug. Some cases you may get 100%, some cases you may get only 1 or 2% of the drug, depends on the situation. And then we'll end up getting a drug concentration within the systemic circulation. When I mention that, it means if I were to draw a plasma level of blood, if I were to get blood out of you, I can measure the amount of drug that's in there in that central circulation in the bloodstream, okay? Now we know that all drug does not stay within the bloodstream. A lot of it will partition out into the tissue. And so we call that distribution, where the drug goes from the bloodstream after it gets absorbed from wherever it is from, and it will distribute out into the tissues. Some things like to distribute a lot into the tissues. Some things don't like to do that. And it will depend on its hydrophilicity and its lipophilicity, right? So all these terms are coming back to haunt you, right? And then eventually you're going to have elimination of the drug as it gets metabolized or excreted. What are some places you think drugs get metabolized? Liver is going to be the biggest one, right? Think of any other places? Kidney, sometimes you have a little bit of metabolism there. Sometimes the lungs can actually have some limited metabolism. The lion's share is in the liver, but you can have some happening elsewhere. But excretion is the other big thing we're focused on. It's the elimination of the drug itself. And the kidneys are going to be one of the primary organs used for that. Also the liver and the bile duct and things like that. So again, this is going to be the pharmacokinetics. This is how your body's handling the drug, how it distributes it, metabolizes it, absorbs all that good stuff. And then once we get the actual drug concentration at the actual receptor, wherever it's going to be working at, you're going to see the pharmacologic effect, right? You can either see toxicity, you can see efficacy here, and this is all going to be focused on the pharmacodynamics, right? So again, what the drug is actually doing to us and to cause its effects. We also have pharmacogenomics. If you guys had to guess, what do you think pharmacogenomics is? Yeah, the effects of genetics have on drug response in a person, right? So you can see in some cases patients may metabolize drugs differently based on their genetics, right? So you can have some people who metabolize drugs very quickly, some people who may not metabolize drugs at all, right? Specific drugs, it's all really back to specific enzymes and things like that. Some patients may respond more significantly to certain medications, some may respond to a lesser degree. Some of it will depend on pharmacodynamics, and some of it will depend on the kinetics of it. Okay. A really good example of this was patients who, we had children, and this is kind of a nationwide thing that occurred. You'd have children who had obstructive sleep apnea because they had swollen tonsils and their adenoids, and so they would go into surgery and have a tonsillectomy, adenoidectomy, right? And so what do you think happens after surgery when you kind of cut out that tissue? Do you think it just kind of goes back to normal immediately? Yeah, it swells up, right? So anytime you're causing, you go to surgery, you're having swelling, you're having some edema there. And so one of the things they were running into is that they were giving these patients pain medication, right? So you guys ever heard of codeine? What is codeine? Do you think of what class of drugs it is? If you had to, yeah, it's an opioid, right? So codeine actually itself is not a very good analgesic, right? It doesn't really provide a whole lot of pain control. But when you metabolize it in the body through a certain enzyme, it turns into morphine, right? So that's where the actual analgesia comes from codeine. And so for these patients, they actually had too much of this enzyme that metabolized the codeine way too rapidly, and they got a ton of morphine out of it, right? And it was actually patients from specific African descent and also I think from certain Middle Eastern descent. And so basically they had too much of this enzyme activity, and so they were out of surgery. They had a swollen throat, right? They already had a history of obstructive sleep apnea, and now they had too much morphine in the system, which caused respiratory depression. So they actually found a few deaths associated with that, related back to this genetic mutation, right? Or just what their genetic makeup was based on their ancestry. And so this is one of those cases where in children, we actually don't even recommend codeine ever at all. We took it off our formulary no more. We just don't use it because the risk is just too great there, right? So it's one of those cases where you can see the drug selection changes based on things like your pharmacogenetics. And so this is becoming a lot cheaper and easier as we get more experience with it. We're getting better tests that we can look to see things like anticoagulants. Who's going to respond well to this drug versus who doesn't? If we can do that, you can avoid a lot of costs associated with, say, laboratory monitoring, avoid hospital admissions due to bleeding, things like that. So this is becoming a lot more common, and you may actually see a lot more of this as you get more advanced in your clinical career. Okay, so again, what's a drug? What is drug? Drugs are bad, right? Don't do drugs. Just kidding. We like drugs here. So again, this is going to be any substance. This is going to be bringing about some sort of biologic change through its chemical action, right? So for instance, here I just put a triangle here, but again, think back to this receptor drug, think lock and key kind of mechanism here, right? So we're going to have a drug. Every drug is going to have a specific shape, form to it. Some of them can be very, very small, even things like lithium, right? Lithium is a drug. It's just a cation, right? It's very, very small versus things that are very large molecules. You have large biologic molecules that are full of proteins that have to be injected. So drugs can come in many shapes and sizes. But we know they're going to interact with a receptor, and again, only specific drugs will interact with specific receptors, and it's very going to be dependent on what tissue it's in, with the cells even express that receptor. But basically, it's going to be the lock that the drug is going to be interacting with. Usually, it's going to be located on the cell surface. Again, located in that lipid bilayer. Sometimes it'll actually be intracellular. In some cases, drugs will be able to cross that lipid bilayer, either through some kind of carrier protein or just through a simple diffusion, but it's able to get intracellular. But most of the time, it's on the cell surface. And it will, when it binds, it's going to initiate some sort of change, some kind of biological event that will lead to the observed effect, whether it's to drop your blood sugar or to decrease your blood pressure or whatever it happens to be. Again, most receptors are going to be proteins. Sometimes we're affecting enzymes, sometimes we're affecting specific transporters, and even in some cases we'll look at DNA targets. We mentioned the chemotherapy, how we can actually have drugs that can go in and interfere with DNA polymerase, causing a premature termination of DNA strands, right? And that can cause apoptosis to occur. So we're going to see some examples of where that can kind of come about. And so there's also a lot of regulatory role in your receptors in determining how you respond to a drug over time, right? So this is that negative feedback inhibition kind of at play here, where if I were to give you a drug that activates a receptor on your cell surface, and I keep activating it over and over again, do you think that receptor wants to stay activated? Because remember, you want to maintain homeostasis, right? So it's like, hey, this is new, I don't like this. So it can actually downregulate the receptors that it has. They actually decrease the number of receptors for drug to bind to, right? On the flip side, if I'm blocking a receptor, the cell can actually respond by increasing the number of receptors available for substrate to bind to it. So we'll talk about upregulation and downregulation, how that can affect how a person responds to a drug over time. Again, another term I use, ligand, is just something that binds to a receptor. You can see here this drug ligand concentration. Again, typically you have less drug than you do have receptors, but again, you can have a saturation phenomenon that can occur where I can saturate every single receptor in the body for a particular receptor with a drug. And basically, that's the maximal effect that you're going to get. And we'll talk about that more when we get to dose-response relationships. But just realize it's kind of a constant interplay between the drug binding and releasing off the receptor. We'll talk about some things that bind very tightly and don't like to come off the receptor. Some things will bind kind of freely on and off of that receptor itself. But just know there's going to be kind of an interplay between bound and an unbound state. Okay, so again, this ligands could be also referring to kind of endogenous products that can bind to a receptor. So again, I think about insulin. Insulin is an endogenous ligand that binds to insulin receptors, but we can also give you exogenous insulin as well outside of the body. It does the same thing basically. Other examples include neurotransmitters. We'll talk a lot about epinephrine, serotonin. Where do you think serotonin is useful in as far as like medicine goes? Yeah, depression's a big one. So we'll talk about serotonin and how we can affect that with medications that increase levels of serotonin. We talked about hormones like cortisol, insulin, even drugs like acetaminophen can be considered a ligand. And then we'll also talk about messenger molecule like antibodies as well that can be, again, binding to these receptors to cause a clinical effect. Hormone, we already mentioned in the physiology class, but again, just a natural substance that the body is producing to influence the way the body grows or develops. So we'll talk more about this in the endocrine section of physiology, but usually it's going to be a drug that is basically synthesized within the body. So it could be insulin, testosterone, cortisol, all these things can act as hormones within the body. And then a xenobiotic is basically anything chemical compound that's foreign to a living person or organism, right? So if I give you penicillin, does your body normally produce penicillin? No, so that would be considered a xenobiotic. That's not a common term that we use, but it is just for sake of completeness, we'll mention it here. Another term, toxin. Usually toxin is referring to kind of natural products of biologic origin. So if you think about like snake or spider venom, it's considered a toxin. Botulinum toxin is actually one of the world's deadliest poisons that are out there, right? And what do we use it for? Look beautiful forever, right? I'm really surprised. We also use it in some other places as well, like hyperspasticity of certain muscle groups. But usually you're going to see a lot of toxic effects associated with these. Sometimes therapeutic ones in the case of botulinum toxin. Toxicant is going to refer to anything that is non-biologic in origin. So if you think about things like lead, pharmaceuticals, anything the body's not used to, that's not biologic in origin, would be considered toxicant. You'll hear me kind of interchange the two terms, but just for completeness sake, here's the kind of the actual definition there. And then toxicology, which is really my focus, is the study of harmful or poisonous effects of drugs, right? So I like pharmacology. I like the idea of like what drugs do at therapeutic effects. I really like what they do at toxic effects, right? So especially when you have patients who overdose on, just handfuls of different medications, how those interplay with one another and cause, how a patient presents can change drastically based on what they ingest. Like, it's super cool, I think. So I like to really focus on the toxicology. So I'll use a lot of examples like that to illustrate certain points as we go through this class. Okay, so an agonist. What do you think an agonist is? Does something? Yeah, basically, it binds to and activates something. Huh?
I said helps do something.
Oh, it helps do something. Okay. Either way, yeah, it helps do something, it does something. Yeah, basically an agonist is going to be something that binds to and it activates a receptor. Yeah, if I ever missay what you say, because I sometimes have bad hearing, feel free to correct me. But anyway, yeah, so it's going to be binding to and activating a receptor, right? So it's going to be causing a positive effect on that receptor to cause whatever change it happens downstream. Sometimes it'll either be directly by binding to the receptor, sometimes it'll be more indirect in how it works. We'll talk about some examples of that later on, but just realize it can be either direct or indirect. But a good example of this, you guys ever heard of the drug albuterol? What do we use that for? Asthma, right? We use an asthma during an asthma attack because we have the bronchial smooth muscle is constricting, right, and it's impeding airflow. So what we can do is use a beta-2 agonist, like albuterol. You inhale that, the drug is going to partition into that bronchial tissue. It's going to activate beta-2 receptors, and that causes smooth muscle relaxation. So now all of a sudden your bronchial airway starts to open up, the radius starts to increase, and you can have more airflow going in, right? So that's how they get that relief of the bronchospasm that happens in those patients. There's a term affinity. Affinity is going to describe how tightly a drug binds to the receptor. So you can find things that have very low affinity, that don't bind very tightly. They kind of have that interplay between drug and receptor to actually being bound and unbound is a very quick process, right? Some things have very high affinity, and once they lock onto that receptor, they're stuck there, right? They'll be stuck there for a long time. So we talk about drugs that have high or low affinity. And then oh, yes, ma'am.
Does the affinity have to do with just the stability of the compound liquid molecule that's being used?
Not necessarily the stability of the molecule, because sometimes you'll have drugs that, because the stability is kind of referring back to how easily it gets metabolized, right? How long it sticks around the body. Sometimes you can have drugs that have a very high affinity. Then once they're bound to that receptor, they like to stay there, and so they actually have a longer. We'll talk about metabolism, how long that takes. We'll talk about half-lives, right? That even if it was unbound, it would go and get metabolized very quickly, but because it's stuck there on the receptor, it doesn't get metabolized very easily. That can actually cause it to have a longer half-life than what you would expect based on the stability of the molecule. Yep, so it really just has to do with how tightly it's binding to that receptor. We'll talk about potency in regards to how the amount of drug needed to cause a response. So say, for instance, if you have a very high potency drug, you only have to use a very small amount of it to actually get a biologic effect, right? So say, for instance, the drug morphine, again, analgesic, providing pain relief, is going to be dosed in milligrams. I can give you 2 milligrams of morphine, you guys will be feeling pretty good, right? On the other hand, you guys ever heard of the drug fentanyl? Yeah, fentanyl is another very potent analgesic. We use a lot in the surgery setting, or we use a lot in the ERs. That one is only dosed in micrograms. I can give you 20 micrograms of fentanyl, and you get a pretty good effect of it, right? So micrograms to milligrams, what fold difference is that? 1,000-fold difference, right? So again, you can have drugs that are very, very potent, dosed in micrograms versus things that are dosed in grams even, right? So very big, wide range of doses that we can give for different drugs, okay? So things that are more potent require less drug to get the same effect, essentially. Efficacy is going to go back to the maximal effect that you can actually have to have the desired response. So say, for instance, if I give you a drug, A, say call it drug A, and it doesn't matter how much I give you, you're only going to see, say, a 10-point drop in your blood pressure. That's somewhat efficacious, but not super efficacious, right? On the other hand, if I gave you drug B, and I can get a drop in blood pressure of, say, 30 points, it's going to be much more efficacious, right? So it just depends on how big of a therapeutic effect I can get out of that drug. We usually like things that are more efficacious, obviously. And then clinically, when we're looking at dose-response relationships, it's much more important that we focus on the actual efficacy of a drug rather than the potency. Okay, it doesn't matter how if I have to dose a drug in grams if I get the same response as a different drug I dose in micrograms. Okay, when you look at drug dosing, we've kind of figured that out as far as like how much to give in order to get a clinical effect. So we're really looking more at efficacy than potency when it comes down to selecting a drug for a patient. Okay, and just to give you an example, you can have equal potent doses of drugs to one another. Kind of mentioned milligrams of morphine versus micrograms of fentanyl. Same thing here. If you had drug A, 100 milligrams would cause a 20-point drop in blood pressure. Could be the same as 10 milligrams of drug B, cause the same 20-point drop. Okay, so it'd be equal potent doses because they're causing the same therapeutic effect, even though I need different doses to do it. Okay. And so we do this very frequently when we are converting patients from one type of drug to another. So say, for instance, if you think about a hospital pharmacy, do we carry every single drug ever made? No, it's cost ineffective. It would be, be out of business if that was the case. We have a formulary, right? It's going to be certain drugs we say, these are the drugs we want to have on formulary for our patients. Does the patient always come in on those formulary drugs? Oftentimes they don't, right? So in a lot of cases, we have to actually convert them over from one drug to another to get the same type of effects. We do this a lot for cholesterol drugs. I can say, okay, well, I know that 20 milligrams of atorvastatin equals 10 milligrams of rosuvastatin. And so if atorvastatin is my formulary drug, I can convert a patient over from one to the other and get the same therapeutic effect. So those would be equal potency, right? And so there's tables and things like that are developed for different types of drugs to look at that. Okay, so then looking back at agonism, so a full agonist would be something that when it binds to that receptor, it causes 100% effect, right? It's going to cause the maximal effect it can as it's bound to that receptor. So if you bind up every single receptor available, 100% of them, you get 100% effect, okay? That would be a full agonist that, the maximal effect you're going to get is when you have full receptor occupancy and you're going to get maximal effect out of that, okay? It's going to be in comparison to a partial agonist that will bind to a receptor and only partially activate it. So it can bind just as well as a full agonist, but the actual full effect you're going to get from it is maybe only going to be 50% or 75%. It will never be 100% because it only partially activates that receptor. I'll show you some examples of that in a chart in just a second. But again, it doesn't matter if I have 100% of the receptors bound up, I'm only going to get, say, a certain percentage of that effect as compared to a full agonist. Again, to give you kind of a pictorial example, it doesn't matter how many of these receptors I've bound up, there's only a maximum effect I can get from a partial agonist versus a full agonist. And if you looked at the actual effects, if you're looking at the therapeutic response I was getting from these drugs, so the response here versus the concentration. Even as I start to increase the dose of both of these drugs, notice here that the maximum effect of the full agonist as it binds to 100% of the receptors, right? Because that's where you get that plateau effect. So once you kind of bind up all of your receptors, that's 100% bound. This is the full effect that you can get from that. Versus a partial agonist, once I bind 100%, it's only going to be about maybe half that or a certain percentage of.
What's the benefit to a partial agonist versus a full agonist?
That's a very good question. I'm glad you asked that. So, for instance, say for opioids, is that considered an addictive substance? Not. Yeah, we're in the middle of an opioid epidemic. It's highly addictive, right? So in some cases, we can actually give patients. And what happens if someone who's like, say, they do heroin every single day, and I cut them off their heroin all of a sudden? What happens? They withdraw, yeah, and so it's very, very unpleasant for them. Oftentimes they say, this is too bad, I'm going to go back and do more heroin, right? If we're trying to get someone off of opioids, what we can actually do is put them on a partial agonist that just kind of only somewhat activates the receptors and actually prevents withdrawal from happening. So there's a drug called buprenorphine or Suboxone, if you ever heard of that. That's a drug that we use for that purpose as a partial agonist. Almost like a plan nut myself. Great segue. On the flip side of that, we have antagonists, which are going to bind to a receptor, but actually don't activate it at all. Okay, so it'll block or reduce the action of other agonists from coming in and binding it. Okay, so say for instance, I guess I've heard of a beta blocker, right? So think about the drug propranolol. It's a beta blocker. It's kind of a very common one. When it sits on the heart, on those beta receptors, it prevents things from epinephrine from binding to it, right? So its whole therapeutic effect is just to prevent epinephrine and norepinephrine from binding to that, and that helps to reduce heart rate, reduces blood pressure through the ability to block those receptors. Okay, we call that a competitive antagonism, where basically if you were to you have an antagonist on board sitting there binding all those receptors, if I increase the concentration of an agonist to a high enough level, I can actually overwhelm that antagonist and kick it off the receptor. I'll show you an example of that in just a second, but basically a competitive antagonist is all going to be a numbers game, and so if I have a lot of substrate, a lot of things are going to activate that receptor, I'm able to overwhelm the antagonist in some cases. Okay, so it'll be competitive antagonism. On the other hand, you can have drugs that bind to other sites on the receptor and prevent the agonist from actually having full effects there. So it'd be called an allosteric antagonist, where they would actually fit on another spot on the receptor. You can have a chemical antagonism where you can actually have a drug bind up to the actual effector, right? The actual thing that would have bound to that receptor in the first place and prevent it from being very effective. So say, for instance, like a good example of that would be drugs that are based off of antibodies. So a good example is we have a drug, you guys ever heard of digoxin? It's a heart medication used for arrhythmias. If someone were to overdose on digoxin, they have way too much of an effect on the heart, and you have arrhythmias and die. Right? We have an antibody that is actually made from sheep proteins that we can inject into the person and actually binds up the digoxin and prevents it from getting to the heart. All right, so that's one way we could do a chemical antagonism for digoxin. And then we could have a functional antagonist, so it would be where something indirectly or inhibits the physiologic actions of an agonist. So imagine this, like, what effect do you think like amphetamines, like methamphetamine, has on blood pressure? They increase or decrease? It should increase, right? It's a stimulant, right? It helps to increase heart rate, increase blood pressure. But what if I gave an antihypertensive at the same time? They have kind of intrinsic antagonistic effects to one another, and so by giving someone amphetamines or cocaine or something like that, they're blocking the effects of the antihypertensive, right, and making themselves increasing their blood pressure. So you can see where people will be on medications in some cases that directly antagonize one another just through the physiologic effects and not through the same receptor sites. And again, they're not having any activation of the receptor itself. That's kind of intrinsic to being an antagonist. Again, just another kind of pictorial example of this. Where you have a natural chemical or a natural ligand that would go in and bind to a receptor site. If you were to have, say, a drug, like an agonist, it would come in and again fit the same basic shape as whatever the ligand would have been in the first place to cause some sort of physiologic effect. Antagonists, on the other hand, are going to block that site and prevent drugs or the natural ligands from coming in and binding it. Okay. You'll find some things can be reversible or irreversible antagonists. Basically, it goes to how long the drug effects are going to stick around for. So a good example of this is going to be between ibuprofen and aspirin, right? So when people take 81 milligrams of aspirin a day, a little baby aspirin, what are they usually using it for? As a blood thinner, right? Because it helps to prevent what? Heart attack. All right, exactly. So the reason why we can use such a little baby dose of aspirin for these adult patients is because it's an irreversible antagonist for this enzyme cyclooxygenase. Okay, so that means once it binds to cyclooxygenase, it's bound there until that enzyme is degraded and produced again. So that means that even though I'm taking only 81 milligrams a day, those clinical effects, that blood thinning effect, sits around for a long time, usually for the lifespan of that enzyme, or in this case, of the platelet. On the other hand, you can have reversible antagonists like ibuprofen, which will bind to the same enzyme, but it will also unbind from that once the drug is metabolized. So that way you end up seeing worse bleeding effects from aspirin than you do from ibuprofen because of that reversibility of it. Okay. We mentioned the competitive antagonists. Again, there's going to be competitive versus non-competitive. A lot of it has to do with the binding of it to which site it's binding to. Competitives, again, can be overwhelmed by an agonist if the numbers are right. And we'll look at a graph of that in just a second where you're kind of compare and contrast the two. But in some cases, non-competitive antagonists are going to bind to a different site that actually will, it doesn't matter how much of the agonist you have around, you're never really going to get that full effect from it because it's binding to another site to maybe change receptor conformation or doing something to make it less effective. So again, if you were to, say, give a drug as an agonist, and we're looking at the agonist effect, so maybe like blood pressure drop or whatever happens to be, and then the agonist concentration, as I increase that, obviously if I'm giving it by itself, I'm seeing kind of a plateau effect. And what's happening at this plateau effect? Yeah, I'm binding up all the receptors that are available, right? So that means I have 100% receptor occupancy at this point, right? That's why I hit that plateau. On the other hand, if I were to give it with a competitive antagonist, as that concentration increases, notice that there's the plateau is a whole lot lower, right? Because the two are kind of fighting one another for that site, right? It's like you guys are fighting for parking spaces or something. Only one person can fit in that parking space at the same time, okay? Eventually that person's going to leave, and then the agonist can get in there and get into the receptor. But again, it's not going to be as maximal of an effect as long as you have that antagonist around. Okay. So this is a really good example of this. Again, I like going back to illicit drugs. So those are my favorite. But looking at opioids. Okay, so opioids. You guys ever heard of the drug methadone? Yeah, so this is a drug we sometimes use to help patients get off of opioid addiction, right? So if they've been addicted for a long time, we can help them get off with methadone by preventing withdrawal, essentially. But that is a full agonist. You guys know what receptors opioids bind to? Opioid receptor. Very difficult, I know. Again, if it sounds too intuitive, it probably is. So anyway, so something like methadone is a full agonist. It'll bind to that receptor and cause maximal effects from it, right? So if you expect, see someone who's on an opioid, expect them to get sleepy and maybe stumbling around and not breathing is like kind of the big thing we worry about. On the other hand, we can give an antagonist called naloxone or Narcan. You guys ever heard of that drug? Yep. So that's an antagonist. Basically, it's going to sit on those opioid receptors and prevent methadone from binding to it. Okay. So as long as I give a big enough dose of naloxone, I can provide enough competitive antagonism to prevent that methadone from having its effect. So if anyone's ever seen someone who's received Narcan after they overdose like on an opioid, it's like immediate. Basically, the Narcan kicks the drug off the receptor and they wake up immediately. And they're wide awake and they're usually going into withdrawal and they're like, "Where's my drugs at?" Okay. So try to prevent that when best we can, but that is one of the things that can occur there. So that would be a competitive antagonist versus a full agonist. Okay. On the other hand, we have something like buprenorphine, which we already mentioned as being a partial agonist. And again, it doesn't matter how big a dose we get, you're never going to get the same type of clinical effects as you expect to have a methadone because it only partially activates those receptors. So it doesn't matter how much I overdose on, I'll never get the same kind of high or same kind of effects I would get out of methadone because it's never going to activate those receptors fully. Okay. So we had actually a really interesting case one time. I was in fellowship, and basically we had a patient who EMS called in, and they said, "Hey, we have a patient who's coming in. They overdosed on buprenorphine." They said, "Okay, what I expect to see when that patient comes rolling through the door, someone who's very sleepy, they are possibly not breathing, might need to intubate them in order to breathe for them, may need to give them naloxone so they can breathe again." This patient came in, she was kicking, screaming, biting people, trying to, she was in 4-point restraints, just going crazy. We're just like, well, this doesn't look like a buprenorphine overdose. Like, this doesn't seem correct. And so eventually we got her calmed down. We were like, well, what the heck happened? And she said, well, I ran out of my methadone, and I took all my friends' buprenorphine. Suddenly it makes sense because normally she's used to having a full agonist effect around all the time, right? She's used to having those opioid receptors getting that full effect, 100%. Now all of a sudden when she took this buprenorphine, which actually has really high receptor affinity, more so than methadone, it kicked all the methadone off those receptors, bound to it, and now we're only getting like 50% activation. So essentially she put herself into withdrawal by taking an opioid. Based on the receptor pharmacology, you can see how that can occur, right? So it's one of the things where like, it doesn't make sense based on what you're hearing, but once you have the history, if you know the pharmacology, it makes a whole lot more sense. Does that make sense to you guys? So again, just kind of cool stuff you can see when you're starting to mix and match drugs, especially in overdose. Okay. So looking at receptor specificity, again, you'll find that we like drugs that have a high specificity, right? Specificity means it's going to be acting on one type of receptor. It'll be activating only very specific types of tissues or cells, right? Because of that, because it has such a narrow spectrum of activity, it's only going to have limited toxicity, which means you have limited adverse effects we're going to expect to see. So for example, we mentioned antibiotics just in the past hour, saying that antibiotics target bacterial ribosomes, right? They leave our ribosomes alone, so that's why we don't get a lot of toxicity from that, as opposed to the bacteria, which they get killed off, right? That's what we kind of want to do to the bacteria. On the other hand, we have a lot of drugs that have low specificity, where they affect a lot of different receptor sites. They are not specific for any types of tissue or cells, so they affect tissue all over the body, and they have a lot more adverse effects because of that. Okay, so good examples of that we mentioned the chemotherapy drugs, right? So we said chemotherapy, we want to kill off those cancerous cells, but what does it do to your hair? Oh, they fall out. It's not an intended effect, but it's an adverse effect because it's affecting all of those rapidly dividing cells. Okay, that's a problem. It causes that diarrhea because it's affecting your GI cells as well. We have tricyclic antidepressants, which we use for older drugs that are used for depression. Those affect all types of receptors, and they're very, very dangerous because they cause so many adverse effects. Right, so we like things in narrow spectrum with high specificity, but in a lot of cases we may not be able to do that. Another good thing to mention here is going to be stereochemistry. So you guys remember isomers, and you guys remember enantiomers. Hopefully, you guys, I see a lot of blank faces. That's okay. That's fine. So when a drug has, or a molecule, basically, we talk about chirality because in a lot of cases, drugs that have 4 different things binding it at a given site, you're going to see that 50% of it may be in this one configuration, say like the R configuration, 50% will be in the S configuration, right? You're going back to organic chemistry, right? So basically, we call this a racemic mixture when you have a 50-50 blend of both of these drugs, right? And it's basically like looking at your hands, right? Even though your hands look identical, they're not mirror images. They're mirror images in one another. You can't overlay them together, right? So they work differently in the body in some cases by binding differently to receptors. And so what you may find in drugs, even though we give them as a racemic mixture, being 50% S and 50% R, you may find that one enantiomer is going to cause therapeutic effects, and maybe the other one's only causing toxic effects. Okay, and so in some cases, you can actually separate those out into making a brand new medication. So a good example of this would be like, say, albuterol. Albuterol comes as a racemic mixture. Well, if I go ahead and pull out the left-handed molecule of that, now I have levalbuterol. And now it's going to be called Zopinex, and I have a brand new brand name drug. And so that also means a heck of a lot more money for the drug manufacturers, because we'll talk about how drugs get onto the market. But basically, and whenever you have a new one of these molecules, you get a brand new patent, which means you got 20 years exclusivity on that drug. Okay, we'll talk more about that in detail in just a second.
So you're assuming that the right-handed molecule that has no therapeutic effect.
That is what they will tell you. You will find I may be a little bit cynical of these drug companies. Even though I peddle their wares, I'm on to them. What's going on? But clinically, what this means is that you can interconvert between these two drugs very easily based on their doses, right? So for instance, if I have 5 milligrams of a racemic mixture, that means 2.5 milligrams of the left-handed, 2.5 milligrams of the right-handed. So if I had someone who was on 2.5 milligrams of Zopinex or levalbuterol, which is very, very expensive, I can convert them over to 5 milligrams of albuterol, and they get the same therapeutic effect, right? Okay. Same thing for, here's an antidepressant drug called citalopram or Celexa. They have escitalopram. Okay. This is just one of the enantiomers, so 10 milligrams of escitalopram equals 20 milligrams of citalopram. We do that very frequently for a lot of patients because we will only carry citalopram at Nemours. Patient comes in on escitalopram, we'll convert them over to citalopram and just double the dose, right? And therapeutically, they get the same effect because it's the same amount of active molecule. Yes, ma'am.
So these examples are enantiomers important.
Yeah, so these examples are the racemic mixtures. These are examples of the enantiomers that were marketed as brand new drugs, right? So you have one like cetirizine. You guys know what you use cetirizine for? Used for seasonal allergies. Now they have levocetirizine or Zizal. Okay, just to give you an example of, I don't have completely unfounded. I found this on the website. I was looking this up, and say, oh look, wisely designed to be different. Right, they get a brand new patent out of this. The active enantiomer of Zyrtec with no dextrocetirizine. Right, so we said is levocetirizine. Now we have the no dextro. Right, we got rid of that dextro. That stuff was no good. Right. The clinical relevance regarding the absence of dextrocetirizine is unknown. There's no clinical evidence to show that that drug is any better or worse than using the racemic mixture. But they get a new patent, they get a heck of a lot more money out of it. And like, how many of you guys knew about this before you came into this class? 1 person, 2 people, like not many, right? So a lot of people go and say, this is the new thing, I gotta buy the new thing, this is good, right? Not necessary, it could be just as good as the old thing. So there'll be a lot of examples of this as we go forward, you'll see. Any questions from the first half? Just to clarify, for that slide that had the enantiomers versus the racemic, the racemic mixtures versus the enantiomers, the one with the larger milligram amount, that was the racemic mixture, right? So that was 50% left, 50% right. The enantiomers were on the right-hand side of that slide. That was just half of the racemic mixture. Yes, ma'am.
Is there ever a case where the other enantiomer, like that they don't choose, is having a negative effect, or is it just having no effect in the original drug?
So in some cases, it could be that it's causing adverse effects, right? So you could see the non-active molecule be causing adverse effects, and that would be a good reason to use the enantiomer, right? In some cases, you'll find that it either did nothing or it caused negative effects. But if you think about it, like you think about the receptor occupancy, in some cases you may have, if you have one that doesn't do anything, binding at the receptor, it could be blocking the active drug from actually doing something, right? Clinically, though, it's hard to have trials that really show that effect, though, right? And so, and I was mentioning to one student that in a lot of cases they'll play kind of unfair comparisons between 2 drugs, right? So for instance, with albuterol example and levalbuterol, when they did trials as a head-to-head, they did 5 milligrams, say, of albuterol versus 1.25 milligrams of levalbuterol. Well, it's not a fair comparison. It'd be better if you did 2.5 albuterol versus 1.25. But by doing that, they were able to say, well, look, there's less side effects with levalbuterol. It's like, well, yeah, because you're using less drug, right? So of course that makes sense. But you know, that still is enough to get by the FDA, and they get approvals for that, and then blah blah blah.
Do they like are they naturally in a racemic mixture? Is that why they're made that way, or?
It depends on the chemical structure. So if they have a specific enantiomer, if they have that chiral point, right? So again, if you go back to your OChem, if a carbon has 4 different bonds to it, 4 different things it's binding to, that makes it have a chirality to it. And so that's what leads to having that 50% R and 50% S. Yep. Someone else have a question? That's it. Okay. Continuing on with the definitions. So downregulation. This is a process where if I'm constantly activating a receptor, in order to maintain homeostasis, your body is going to respond by saying, well, hey, I don't want all this activation. I want to shut down some of this effect, right? And so they can do that by downregulating the number of receptors that are available to actually bind to. So that will lead to total reduction in the number of cell surface receptors that they can bind to. So fewer receptors means fewer clinical effect that you can expect to see from those drugs. That means that in order to counteract that, you may need to actually increase the dose of drug in order to find more receptors to interact with, right? Because again, when you're giving a drug therapeutically, oftentimes you're not hitting 100% receptor occupancy. You're more likely to see adverse effects at that point. But by giving a higher dose of drug, you can hit more receptors and overcome that downregulation. That's a complicated question. Yeah, SSRIs are pretty complicated. We don't even actually know how they really work for depression, right? We know what their mechanism of action is, we know what they do, but that doesn't explain why they work the way they work, right? But some of it was thought to deal with receptor downregulation by increasing serotonin concentration. So for those of you guys who don't know, SSRIs are selective serotonin reuptake inhibitors, right? The mechanism is right there in the name. It actually prevents serotonin from being recycled back into a neuron, right? So it keeps more serotonin in the synapse where it can activate those receptors. It's thought that if you increase those receptors, the activation, they eventually downregulate and causes some other downstream effects that leads to alleviation of depression. But that may not be the full story, so it's complicated. Again, there's a lot of drugs where we're like, oh, we don't know how it works. We just know it does. And that's good enough for us, so we just go with it. And you guys like to have black and white, but in a lot of cases there's lots of gray out there. And again, you can also find the flip side where you actually have upregulation, where you can have more receptors being brought to the cell surface, and you normally see that with antagonists. So if you have something that's blocking those receptors from being activated, the body says, hey, I want more activity here. Let's make more receptors available for something to bind to it. Bioavailability is a term we use to describe the amount or percentage of drug that is absorbed through a given route of administration. So this can vary pretty greatly based on the drug and also based on the route of administration. So if you imagine something like intravenous, where I'm giving a drug straight into a vein, that's 100% bioavailability. All of it's getting into the bloodstream through that syringe, right? Versus oral, has to go through the GI tract. It may be affected by stomach acids. It could be affected by pH. Lots of different things can factor into it. And some drugs cannot be given orally because they don't get absorbed at all. Some drugs have very good absorption, and so you can have 100% bioavailability. All depends on the drug. And we'll talk about different circumstances and how that can change. And that's why sometimes when you look at dosing of drugs between IV versus oral, sometimes they can have the same dose, which is easy because that means it has a high bioavailability when given orally, and you don't have to worry about converting anything. Sometimes drugs will have a 10-fold higher dose when given orally to overcome that bioavailability, right? So you can find, use say like 0.1 milligrams for drug IV, but you may need 1 milligram orally or 10 milligrams orally to overcome that bioavailability problem, right? We'll talk more about that when we get to the actual kinetics section of the class. Next we have what we call a first pass effect, and so this is going to be what I call the liver tax. And we mentioned that the liver is really, really important for metabolizing drugs. And when something gets absorbed from the GI tract, the first place it hits is the liver. Lots of metabolism happens here. And so the degree to which a drug is metabolized in the liver as it gets absorbed from the GI tract before it gets into the central circulation is called first pass effect. This may be very high. It could be 100% where it binds, or, metabolizes all the drug and makes it so that none of it gets into the circulation, even though it's absorbed from the GI tract. That makes it, so oral administration would not be very good. It could be just a few percent, could be, somewhere in between. So the first pass effect is the amount that the liver metabolizes before it gets into the bloodstream. Okay. Another example of this would be a prodrug. Prodrug is basically going to be an inactive drug. Basically, I give a drug, it doesn't do anything by itself unless it's been activated through some sort of enzymatic process. Usually this happens within the liver. Once it gets converted, then it's physiologically active and can go and have its effect. A really good example of this is a drug called lisdexamfetamine, or Vyvanse. You guys ever heard of this drug? What do you think you use it for? Yeah, ADHD is where attention deficit hyperactivity disorder. So it's a very common one that you use a lot in children. The place where it came from is the fact that there's a high abuse potential for amphetamines, right? They're addictive substances that cause addiction. And so what you would find in some patients who are abusing these drugs, they would take like dextroamphetamine, which is another ADHD med. They would crush it up, and usually they come like an extended release format. They crush it up and then snort it, and they get a whole lot of the drug all at one time. They feel really good, and they go on to it again. Right, but by giving this prodrug, if you were to crush up and snort lisdexamfetamine, you actually wouldn't get very much effect, right? It would take time for that drug to be metabolized, as it would just naturally go through the venous system and hit the liver. So they really don't get a whole lot of effect from that. So they did that as a prodrug to kind of avoid some of that abuse potential. Okay, doesn't mean you can't take a ton of it orally, have it all activate in the liver, but it wouldn't be as fast as you would have it if you snorted it. It's usually a very fast way to get drugs into the bloodstream. So again, just an example of how we can use a prodrug to help prevent abuse rather than just having some other clinical reason for doing that. Okay, volume of distribution, we'll talk about this more when we get to the pharmacokinetic section, but this is going to be a number that's associated with every drug, and basically it talks about or pertains to how farly distributed the drug gets into the tissues, right? So we mentioned that drugs can stay within the central circulation in the bloodstream, they can partition out to the tissues, or they can have some kind of in-between state, right? And so drugs that have very high partition, they like to go way far out into the tissues and preferentially stay there, they have a high volume of distribution. Okay, drugs that have a low volume of distribution like to stay within the bloodstream. They're much more, and this goes back to hydrophilicity versus lipophilicity. Things that like to go into the tissue typically are lipophilic, like to partition out into that tissue. A really good example of this would be THC. Where do you find THC at? Marijuana, yeah. Anyone who answered that a little too quick. I know it's kidding. Right, so you define THC as tetrahydrocannabinol. It's the primary psychoactive component of marijuana. So the thing with marijuana is the fact that it is very lipophilic. It likes to go into the fat tissue, and for people who smoke a lot of it every single day, they can have the fat absorb a lot of that, especially if they have a lot more adipose tissue. They can hold on to a lot of that THC for a long time. And so that becomes important when they're trying to get a job, or they're trying to get into the military or something like that, and they need to pass a drug test. Right? Patients who have a high dose chronic use, they can stay positive for up to a month after their last use in a urine drug screen, because they're just leaching out that THC that's been building up in the tissue over time. Okay, versus something like cocaine, doesn't really have a high volume of distribution, likes to stay in the bloodstream. That gets metabolized very quickly, and you can only measure cocaine in the urine for say 2 or 3 days after last time of use. Okay, we'll talk more about that later, but that's essentially just talking about how far into the tissues a drug likes to distribute.
I'm sorry, what did you say that low volume distribution stays in the bloodstream?
Mm-hmm. Yeah, so usually things that are more hydrophilic, like to stay in the central circulation, they'll stay in the bloodstream, right? And so that'll be important when we're talking about like measuring levels, because again, when you're measuring levels of drugs, you're measuring it from a blood draw, right? You're not like doing a tissue biopsy and determining how much drug is there. So that'll be really important when we're looking at the dose that we give versus the concentration. We'll go over all that later. Okay, any questions on the definitions as we've covered them so far? It's probably a little bit more new material for you guys than physio, so it's at least good I can give you some new information. But next up, we'll have our routes of administration. So this is going to be all the different ways that we can give drugs and get them into the body. So you don't have to memorize this particular table in all of its details, but these are going to be things we'll talk about as we get to individual sections. But basically, here's your routes of administration. The bioavailability is going to be pretty intuitive based on just the mechanics of how you're actually giving the drug. And I'll talk about that in more detail. But some other things you want to remember are going to be some of these characteristics, particularly about onset of action, if it's a painful administration, different things like that. So we'll talk about these much more in detail. But here's the main ways that you may give drugs and get them into the body. The first one is going to be intravenous, and so intravenous administration, I'm sure most of you guys are familiar with this. I'm sure many of you have maybe received a drug intravenously. Basically, the advantages here is a very fast onset. Okay, it means as soon as you inject into the bloodstream through a syringe, through a needle, you're going to get into the bloodstream very quickly. That's going to circulate around to wherever it needs to go, and you can have effects within seconds to minutes. Okay, the other nice thing is that it's very titratable. And when I say titratable, what do you think that means? you can adjust the dose, right? So for instance, one of the things you'll see whenever you give a drug intravenously is that once you give it, like you're kind of done, right? You can't take it back once it's in the bloodstream, right? In a lot of cases. But what you can do is things like continuous infusions of drugs. So we do this a lot for drugs that help to regulate blood pressure, like in those septic patients I mentioned. So if they're hypotensive, I can give them things like dopamine, or I give them an epinephrine infusion, and I can titrate that to make sure their blood pressure stays in just the right range, okay? So I can dial it up or I can dial it down, and because the effect is pretty much instantaneous, I can kind of see real-time feedback of how the dose is affecting that patient. I can adjust accordingly. So that's one of the nice things about that. And again, we mentioned 100% bioavailability. None of it's getting that liver tax because it's all getting into the bloodstream immediately. Okay. Now there is so I mentioned the intermittent doses. That's when we just give basically an IV bolus. You're just giving it as one big push. Again, that's one of those things you can't really take it back once you give it. Otherwise, you can get the continuous infusions, right, where you can dial your dose to however you want it to be. You can do that with things like insulin. You can do it with those vasopressors, like the epinephrine I mentioned. You can do it with fluids. All kinds of different things can be administered this route. And we'll also talk about central versus peripheral administration. So when I say peripheral administration, what do you think that means? Yeah, you usually give it in extremities, either like through the arm, you can do it in the leg, lots of different places you can. Versus central administration, what do you think that means?
PICC line.
So you mentioned a PICC line. What is that?
It's a IV with longer catheter.
Okay, it's IV with longer catheter. You know what PICC means? Peripherally inserted central catheter. Yeah, absolutely. So all right there in the name. Essentially what that means is that you would give a very long catheter, right, either through usually in the arm or maybe like through a femoral vein, something like that. Basically you'd end up snaking that up into the inferior vena cava or superior vena cava, and basically you give all your drug right there, right into the heart. Okay, what do you think the benefit of that is versus giving it peripherally? You may see a little bit faster effect. That could be one thing. Yeah, so again, you're getting into a lot larger volume of blood coming back into the heart, and so it dilutes out the drug very, very quickly, right? And so there's going to be some drugs you only want to give centrally, because if I were to give it peripherally, I can see a lot of damage being done to the tissue, especially if we have what we call extravasation, right? And so extravasation would be if you're administering a drug IV and accidentally infiltrates outside of that vein into the surrounding tissue. So a really good example of this is the drug called phenytoin, which we mentioned previously. We use it for seizures. If you give this drug IV and it extravasates into the surrounding tissue, see all this tissue necrosis happening here? Right? It's a lawsuit waiting to happen. So you have to be very, very careful because it causes lots of tissue necrosis. It causes lots of damage to that tissue. We call it purple glove syndrome. So this is the drug that we'd much rather give in the central administration, to give it that way it's going to be diluted a lot more quickly. It's going to be a lot less harsh on the veins, right? So that's one thing you want to consider. And the other thing to look at is going to be this precipitation of substances. I'm sure some of you guys have been mesmerized by this GIF. But basically one of the things you have to worry about is when you give multiple drugs at the same time, how do they interact with one another? Some of them actually have a physiochemical instability where they combine with one another, they precipitate out. And so what do you think happens when you have precipitated drug entering into the bloodstream? Cause an embolus, right? So not a thrombus because that would be more platelet-based, but cause an embolus where you can actually have crystallization in different veins. You can have a pulmonary embolus that can happen from that. So lots of bad things can occur. This is a really good example of where you do not want to combine calcium and phosphate-containing fluids together. If you were to combine them together, see how this crystallizes out very quickly? You don't want that in your veins, right? So this would be one of the big things we always will check on before you give multiple meds at the same time through the same line, is you want to watch out for those drug interactions where they could be physically incompatible. One, they could just crystallize out in the line and then you lose your IV line, or they crystallize in the patient and that could be bad for them, okay? So all kinds of things we consider before we give a drug in the intravenous route. And again, once you give a drug intravenously, that's kind of it. You can't really take it back at that point. You have to wait for the drug to kind of wear off on its own. Okay. So any questions on intravenous administration? Okay. So continuing on. You have subcutaneous. Some other ways you can see it referred to: sub-Q, SC, SQ. This is going to be good for drugs that we don't really need like super immediate effect for. It's good for sometimes you can have implants that are put in that can be slowly releasing over a long period of time. So for instance, we have some birth control implants that actually will release progesterone or estrogen-based compounds slowly over a period of months to years, which can be very useful because that way you don't have to take a pill every single day. It's good for self-administration for drugs that cannot be given orally. So I mentioned insulin. We said insulin's what type of molecule? It's a protein, right? So if I take a protein into the GI tract, what do you think the stomach acids do to that? Same thing as it does every other protein. It tries to breaks it down to the individual amino acids. So we can't give insulin orally. So what we can do is give it subcutaneously, and this is good for patients who you don't want them to try to start their own IVs. That would be a little too difficult. But you can give it subcutaneously. You just basically jam a needle in their abdomen, and they're good to go, right? They can just inject it themselves. So that's really good for drugs that cannot be given orally. It has a good bioavailability, again, because it's bypassing that first pass effect, so you get good bioavailability there. But it will have a little bit slower onset than either intravenous administration and also intramuscular administration. So it's not super fast, but if it's something like insulin, where I'm only going to give it a few times a day, I don't need it to really work that fast. That's okay. Obviously, the disadvantage, it's going to be a little bit more painful, especially if the patient has to inject themselves multiple times a day. Think about like a new onset diabetic. They may get 3, 4, 5, 6 injections a day they're having to do, and so that can be pretty painful for them. I was just talking to a patient last Friday, an ER new onset diabetic. He's like 6 years old, and now he's going to have to go to a thing where he's injecting himself that many times a day. So it's a big lifestyle change for a lot of these patients. It could be a big impact on their quality of life to consider. Also, you can see some tissue necrosis that happens as well, especially with like anticoagulants. Again, those are drugs that help to prevent blood clots from occurring, but they're doing the same thing in the subcutaneous tissue as well. So if you ever see someone who's on those injectable anticoagulants, you'll oftentimes see that in the abdomen. We also have the intramuscular route. You guys think of any medications you give intramuscularly? Maybe some psych meds, yeah. Yeah, vaccines are going to be another very common one. So vaccines are probably the most common one. My kid just yesterday got her 12-month appointment and had her MMR, and boy, was she cranky. That one does not feel very good. The benefits here, though, is the fact that it's going to be less invasive than an intravenous line. It's going to be a lot easier to get. Also has high bioavailability and pretty fast onset. Not within seconds like an IV would be, but pretty fast. Disadvantages can be very, very painful to inject these, especially the larger the volume, the more tissue you're displacing, and the more pain it's going to cause, right? And so we typically will have limits on how much fluid we'll inject to an intramuscular site. So, for instance, if you have patients who, I'm trying to think, patient like over in the PTER. So if you're, when you're practicing giving IV lines, some of the more difficult patients you'll ever do it in are going to be in pediatric patients, right? Their veins are just smaller, they're harder to get, and so in those patients, if we cannot get an IV line, sometimes what we'll actually do is give them an intramuscular dose, so say like an antibiotic, and that can be very painful, especially if we need large volumes of the thing. So sometimes we'll have to give like 2 injections at the same time just to get the amount of volume in there. But usually you don't want to do more than 3 mLs for any injection. It's usually even less in kids. Now, for drugs to be absorbed, you have to have good blood flow to the muscle. If you don't have good blood flow, you're going to be much more erratic as far as the absorption goes. So if you imagine if you had a patient who was hypotensive, say like due to sepsis, the body preferentially wants to put blood to where? What parts of the body? Heart and the brain, right? So it's not going to send out to the muscle. Like, we don't care about the muscle right now. We need to survive here. So in a lot of cases, intramuscular administration is no good for those patients who are hypotensive, just because they don't have regular blood flow. May have patients who either are obese or emaciated, and they have altered absorption based on that adipose tissue and where the actual injection goes to. And you may actually see that things like exercise or heat may affect the absorption as well. Sometimes you may get a little bit too much absorption too quickly by doing that. And so injection sites that you can give include things like in the gluteus maximus, the deltoid, and the vastus lateralis. Those are usually the most common places you'll see intramuscular injections being given. We also have intrathecal administration. So you guys think intrathecal, what do you think that means? Into the spine. Yeah, so we're actually putting this into the subarachnoid space, and so these are usually done under anesthesia. Obviously, this is going to be pretty painful for patients since they're getting a big old needle in their back. But we can do this in order to avoid things like the blood-brain barrier. We haven't really talked about that much, but basically, the brain's very good at keeping stuff out of it, right? Because it doesn't want a whole lot of toxins there. It really wants to be really selective in what drugs it lets through. But in some cases, we have patients who say need to receive antibiotics. Say they have some sort of infection in the CNS, or if they are receiving chemotherapy, you can give an intrathecal injection in order to administer that drug directly, bypasses that blood-brain barrier. You can also inject into the epidural space as well, and we do that a lot for anesthesia. So we mentioned, where do we do that at? A lot. Yeah, labor is a big one, right? So usually we'll use like an opioid, like fentanyl, and we'll mix it with an anesthetic, and that'll actually be really good for helping to limit the amount of pain sensation that it gets from a certain level. And so basically, the higher up the spinal cord that the drug goes, the more effects that you can actually see. The higher up in the body, you'll see that. So for instance, when you are if you have a lady who is in the middle of labor and she has her epidural going, you can position her in different spots. You can raise her up to if you have too high of an effect on the anesthesia, or you can lay her back down a little bit to get it up even higher, right? So actually positioning her differently can allow the drug to affect different parts of the body, right? So that can be useful if you have too much or too little effect going on. So just some other ways we can do that via the intrathecal route. Next, we have sublingual administration of drugs. So again, this would be right beneath the tongue. You can put it there. This is nice because it does bypass the liver, right? So it bypasses that first pass effect. These are good for drugs who don't have really good oral absorption. Do you guys know of any drugs you can give sublingually? Nitroglycerin is one of the most common ones that gets broken down very quickly in the GI tract. So that either has to be given topically or sublingually or IV. So no oral administration of nitro. Anything else you guys can think of? Made party too hard one weekend. Zofran, yeah, absolutely. So Zofran is an antiemetic. It's commonly given as a sublingual tablet, basically and that's good because if a patient's puking, they probably don't want to swallow any tablets. So you just put it underneath the tongue, absorb very nicely, and then they're good to go. Disadvantage of very few drugs actually go through this absorption, so you may not be able to get a lot of drugs via this. But sometimes you'll see things like acetaminophen. They have like rapid melt tabs, like basically the same kind of process happening there. Okay, next, oral is going to be the most common administration technique that we're going to do here. The advantage here is it's going to be the most common, or the most common method, the safest, and also the most economical. It's very easy to give someone. It does not require a whole lot of skill to give someone a tablet versus trying to start an IV for them, right? The disadvantage, though, it does require patient compliance. The patient has to be able to swallow. And then looking at the drugs and they actually get absorbed, that does undergo the first pass effect. So anything given orally is going to hit the liver first. Some of that drug may or may not be metabolized and then get into the bloodstream. And again, whether the patient is going to comply with you can be a really big deal. And so I did not appreciate how much work it is for pediatric nurses to give drugs orally until I had my own child. They don't like oral medication at all. They'll spit it all over you. So again, if the patient's not compliant, you're not going to be able to get a whole lot of drug into them. Also, you can have things like food-drug interactions. So you can have things like fluoroquinolones, which are types of antibiotics. They can actually end up binding up with calcium. So if you were to drink milk with a fluoroquinolone, you prevent the amount of drug needed to get absorbed, and you may have the infection not be eradicated. You can just continue on with the infection, right? So that'd be pretty bad for them. You'll see different dosage forms. So here, for instance, we have a capsule that has these little pellets in it. This is a good example of a drug that has enteric coating on it. Basically, all those little pellets are those ones that I mentioned previously where they don't dissolve in acidic pH, right? So when they go through the stomach acid, they stay intact. When they get up into a higher pH, when they get to a more basic environment like the small intestine, then all of a sudden that coating melts away and the active drug is available to be absorbed. So it's a very nice thing we can do to help bypass some of those pH effects. You can also have controlled release preparations, and so these allow for administration of drug throughout the entire day. Sometimes we'll do that with certain diabetic medications. Sometimes we'll do it with heart medications. Basically, all it does is limit the number of times a patient takes a dose throughout the day. And so, what do you think? What are the benefits of giving a drug less frequently? Yeah, better compliance, right? Because again, compliance is going to be probably one of the #1 problems you run into. Like, is it the fact that your patient's blood pressure medication isn't working, or they're not taking it? Probably they're not taking it in a lot of cases. And again, patients may not always be forthcoming with that kind of information. So less frequent administration, the easier it's going to be for them to be compliant. You may see lots of different names for this. You may see sustained release, controlled release, all the different formats. They're all basically the same thing of controlling how much drug is released throughout the day. Lots of different ways to do that, but I'm not going to get into too far on the dosage form side of that. But basically, fewer doses is better. We also have rectal administration. This is very good for patients who cannot take oral medications or PO medications. This is nice because a lot of it does bypass the liver for the most part. And again, the rectum is a very nice, highly vascular area, so it absorbs drug very, very easily there. Sometimes you may have some erratic absorption of some of these drugs, and you have to think about the patient compliance as well, right? So kids, especially infants, very, very easy. Just apply the suppository, they're not really going to fight you a whole lot. On the other hand, if you try to give a rectal administration to an adult patient, they're like, why can't I just take a pill? Right? So in a lot of cases, you have to kind of be cognizant of how your patient's going to be able to tolerate that. Okay. You think of any medications you can give rectally? Anyone with kids? Yeah, Tylenol suppositories is a very common one. Any other? Sometimes we'll do things like enemas and whatnot in order to help relieve constipation for patients. That would be another rectally administered drug that we can give. Yep. We also have the inhalation route. So this is going to be good when we want drug directly administered to the lungs and really nowhere else. So this can be really nice, especially for asthma medications, right? So if you're having an asthma attack, you're more concerned with the bronchial smooth muscle. You don't need that drug everywhere else to the body. And the other nice thing is it has very fast absorption. Things that do get absorbed from the lungs enter the bloodstream and get back to the brain very, very quickly. And so this is why things like crack cocaine that is smoked actually has the most addictive properties to it out of all cocaine, because it is so fast acting. Okay, I can talk more about that in detail if you have questions later, but not from personal experience, just from the kinetics of it. Anywho, some of the disadvantages though is technique is super, super important here. And so if a patient is not able to comply with the technique, if they're not able to understand how to use these appropriately, they're not going to get drug into the system, right? So who do you think might have problems with using inhaled medication? Children, right? So we have some ways to combat that. Sometimes we have a little mask that we can put on them if they can't hold the drug up to themselves. We'll also have what we call valve space chambers. So you ever seen like an inhaler with a big plastic tube on it? That basically allows you to put drug into the tube. The drug stays suspended there, and the patient can then breathe it in, right? Because again, as soon as you press that canister, like on a multi-dose inhaler, all that drug's coming straight out. And so if the patient's not ready to inhale that, they're not coordinated, they're not going to get drug into the lungs. Okay? Who else do you think might have problems? Yeah, the elderly patients. So if they have arthritis, if they have any kind of coordination problems, that can be very difficult for them to get the drug into their system. So that's where we also have things like nebulizers, which are machines where basically you put liquid medication into a nebulizer cup, and it will basically vibrate the liquid into a vapor that they can inhale. That can be very useful as well if they have kind of coordination problems. But lots of different varieties. There's meter dose inhalers, which are basically kind of what this lady's holding here, but I would not use an inhaler like that. Probably would not absorb a whole lot of drug. There's also dry powder inhalers. So if you ever seen like those discus kind of inhalers, that's basically just a dry powder where all the inhalational force comes from the patient. Basically, that inhalational force is going to draw the powder out into the lungs. And then also the nebulization I mentioned there. Next we have transdermal administration of drug, and so some of the advantages of this is that it's nice to have extended release type of drug being absorbed through the skin over a long period of time. Some of these patches may be changed every single day, every 3 days, every 7 days. It depends on the drug and the formulation. But again, if you had a patient who had like dementia, had memory problems, being able to change a patch once a week versus having to apply, take a pill every single day may be advantageous for them. So that'd be one example where we do that. All this is contingent on the fact that the patient can actually absorb the drug through the skin. So if it's something that's very hydrophilic, you're probably not going to want to pass through the skin very well. If it's something that's very lipophilic, then it might have a better chance. You should not use it on open wounds. You may actually have way too much absorption at that point, right? So if it's going straight into the bloodstream, that can be problematic, especially for, depending on the type of drug it is. And then one of the other problems I run into from a tox standpoint is that because this whole process here of driving the drug through the skin requires diffusion, right? So going from areas of high concentration to low concentration, there's still a lot of drug left on that patch when you throw it into the trash when it's done being used. And so kids can get into that, they can swallow it, and then end up having toxicity from that. And now they have a patch with the extended release amount of drug sitting through the GI tract until they poop it out. Right, and so I've seen a few cases of that where a drug called clonidine that we use for blood pressure, kid accidentally swallowed a patch like that. Took 2 or 3 days for him to poop it out. But he had low blood pressure, low heart rate associated with that, so it can be pretty bad.
Does this potentially cause similar reactions that like the using iontophoresis, where you can have like chemical burns on the skin or anything like that as well?
You don't typically see. So what is iontophoresis?
It's when you're pushing a drug through the skin, and you usually use the form of you're doing like
Electricity. Yeah, exactly.
So using electricity to pass a drug through the skin.
Yeah, so that's actually kind of a cool dosage form. Probably won't mention it here, but some drugs can use iontophoresis, which you can look it up. But basically, using electricity to help force the drug through the skin. So if a drug would not normally go through as easily or as quickly, iontophoresis can be useful for that. Sometimes these like local anesthetics, like lidocaine, can be used that way. But so in those cases, you may see some degree of burn that can happen from that. You typically don't hear. Some of the problems you can run into, though, is if you apply the patch to the same site every time, sometimes that tissue can get kind of macerated. It may lead to either impaired or too much absorption, so that can be bad. But usually you don't see a lot of chemical burns necessarily. That's a good question, though. Okay. You guys can think of any drugs that come in patches? Fentanyl, yeah, fentanyl's a very common one. Duragesic is the brand name for that.
Nitro.
Nicotine's a big one, yep. Yeah, some birth controls, or like just even hormone replacement therapy for women in menopause. Yep, lidocaine patches, yep, that can be useful. I heard nitro, so like nitroglycerin can come in patches as well. Big thing to remember with these patches though is that it takes time for the drug to diffuse through the skin, so it's not going to be an immediate effect. So if someone's in acute pain, you can't slap a fentanyl patch on them and expect them to have no pain right then. It takes about a day or so in that case for that drug to actually get through. Another very common one you'll see is a scopolamine or transderm scope. It's going to be one of those little patches you put behind the ear before you go on a cruise, right? And that's one of those things you want to tell people, like, do it a few days before the cruise, because otherwise, as soon as you get on there, if you put it on as soon as you walk on board, you're going to get nauseous, right? Put it on a day or two beforehand, the drug's already in the system, they're already kind of used to it, and then that way they can be more ready when the rocking of the wave starts happening, right? Okay. So again, some other routes, so we'll cover when we get to specific sections, but we're talking about ocular administration. We'll talk about that when we get to talking about glaucoma meds. That'll probably be next semester. Oral medications, that'll be things that are administered via which route? Yep, through the ear. Yep, so we have some ear medications we'll give. Typically, a lot of ENT cases, we'll see that being used like otitis externa or media, things like that. And then also in the mucous membranes can absorb drugs as well very easily. So again, any kind of highly vascular mucous membrane can absorb drugs, right? For the most part, especially if they're any kind of lipophilicity. So the vagina can have it, the colon, urethra, nasal administration. We use a lot of nasal administration of certain meds over at Nemours in the ER. So say, for instance, a kid comes in, they just broke their arm, and we need to do a reduction for them. Because it is difficult sometimes to get IVs for them, we can actually give intranasal fentanyl as a pain reliever, and also give another drug called midazolam or Versed. It's called a benzodiazepine. Actually helps with their anxiety. So they're really anxious about the fact they're in this pain and whatnot. You can actually give that to them nasally as well, and that will actually be absorbed pretty readily. So it's a lot more convenient than giving it via IV. Right. So we'll talk about those as we get into specific drug examples in the upcoming semesters. One thing I did not, I don't know if I took that slide out or what happened to it, but there's another route you can actually give that if you cannot get an IV on a patient, what's another route you can use to get drugs into the system? Intraosseous, yeah. So basically, you guys ever seen like an intraosseous drug administration? How do they do it? How do you get it? Drill. It is the most metal way to get drugs into a patient's body ever. Power tools, right? It's awesome. So basically, what are some sites you can use for intraosseous administration? Yep. So you can. Yep. So usually you can either see the tibia, you can see the sternum sometimes being used, the humerus can sometimes be used, iliac crest I believe can be used occasionally. I most often see the sternum or the tibia being used in clinical practice. The nice thing here, we'll use it sometimes in kids if you can't get an IV. So imagine if you are an EMS personnel, you go out to the scene, kids cardiac arrest, you pick them up and you're in the back of a bumpy truck, you're trying to get an IV on this little tiny IV, like it's not going to happen, right? In some cases you can just drill into their tibia. It's a nice kind of non-collapsible vein as you administer drugs to the marrow, administer fluids, drugs, anything like that can go through the intraosseous route. So anything you can give an IV can go intraosseous, and so it's a great way to potentially give life-saving medications. Okay, but yeah, so basically it's like a little gun that has a power drill on it. They used to have the kind of manual means to do this, but most of them come as an IO kit that has a little power drill, so you just and then it's in. Apparently it's not super painful, but I don't want to be the one to experiment with that. So, but actually one time I had a patient who came in cardiac arrest. They needed to get an IO. This is like an older guy, but he unfortunately did not make it. But they were trying to clean up the body and get it ready for the family to view. So they're trying to take this IO. It looks like a big thumbtack almost. Like you have different color plastic on the end of it to indicate the size. So like kids get a different size than adults. But basically they're trying to take it out. So they're trying to pull it out, and then the whole plastic came off. So you just had this like big fat needle like just sticking on this guy's bone. And we're just like, well, how do we get it out now? And I think we need to find some pliers and yanking it out. It was not great. He's already shaking loose the mortal coil, so he didn't care too much. But yeah, anyway, adventures in medicine. Okay, next thing we'll talk about is drug development. So how does drugs actually get from a chemist producing it over to a drug that you can buy from the pharmacy, right? How does that process happen? The Food and Drug Administration, as I alluded to, is going to be the primary people that are responsible for this process. They're responsible for protecting the public health by assuring the safety, efficacy, and security of these drugs. Right? They also can handle vet drugs as well, but they'll handle things like medical devices. They'll do food, cosmetic products, anything like that. That's kind of the purview of the FDA. And so everything that gets put out on the market has to come through them. Okay. So some notable acts, and again, I'm not going to have you guys memorize this list specifically, but just to give you some context. Back in the day, like, you used to be able to put anything into these products, right? Like, do you guys remember what used to be in Coca-Cola? Cocaine. Do you guys know what used to be in 7-Up? Lithium actually used to come in 7 as a lithiated soda. It used to have like heroin you could just buy like over the counter. Like, this is the Wild West back in the days, right? So eventually, in 1906, there's a Federal Food and Drug Act, and so this is kind of the main act that really solidified a lot of the context for what we have today. So basically, one of the things they said is you cannot have interstate transport of either adulterated or misbranded food and drugs. So basically, if you have a label that says this is what's in it, it has to be in there, right? And it really didn't have anything to do with safety or efficacy. You could still basically give any drug you wanted to and be like, sure, this works, and have no idea if it did or not. Okay, so we can see where there's some problems with that. In 1938, there was a problem with this elixir sulfanilamide. Basically, it was an antibiotic that was being used for some of these children, and they didn't realize it contained this product called diethylene glycol. I'm not sure if it was put in there purposely by somebody or if it was an accident, but diethylene glycol is almost like taking radiator fluid, like very, very toxic compound, killed a lot of kids. So then it came about, and they said, okay, well, now we want the Food, Drug, and Cosmetic Act, and so this is kind of really kind of shored up a lot of the problems with that, helped instate some more issues with making sure that drugs are actually going to be safe for people to use. And in 1962, you guys ever heard of the drug called thalidomide? Thalidomide, what's the problem with thalidomide? Yeah, birth defects. Yeah, basically, I don't think there's any cases in the U.S., but over in Europe, they're using it as an anti-nausea medication for pregnant women. And basically, the children would come out with basically these like kind of flipper-looking appendages, right? They wouldn't have good formation of the limbs. So because of that, the FDA over here said, okay, well, we don't want drugs like that coming out into the market. So they did this Harris-Kefauver amendment to the FD&C Act, and basically said that drugs now have to show efficacy and safety before they can come out in the market. So that's where kind of a lot of the current context we have for clinical trials and things like that came about from that time frame. So there are several phases that are involved with drugs getting them out to the market. So initially what you have to do, say you come up with your own chemical compound, you say, I really think this is a good thing, I want to go ahead and try to get some clinical trials started. You have to apply for what we call an Investigational New Drug Application, or IND. And basically that says, hey, you have some initial information regarding animal safety and things like that. You take it to the FDA, show them your data so far, and you say, okay, yes, you're okay to use it for human testing. Okay. Once you have that approved, then you can go ahead and take it into the initial clinical trials. And there's actually like 4 main clinical trials. I'll talk about the 4th one in a second. But phase 1 is basically looking for safety data. Okay, phase 1 is going to be in a very small number of patients, usually between 10 and 100 healthy volunteers, right? So even if it's an antihypertensive, even if it's a drug for diabetes, it's not going to be given to patients with those conditions. It's going to be given to healthy people, just to see how safe it is. Then in phase 2, you're going to give it to a larger group of people. Usually they're going to have the disease state, but now you're trying to determine if the drug is effective at all. You're also looking for safety stuff, but now you're looking for efficacy as well. And finally, phase 3 is we're trying in thousands of patients to establish further safety and efficacy. Yes, ma'am.
So, with your example with the blood pressure medication, you're giving it to healthy volunteers, but if the effect is to lower high blood pressure, what if the effect also lowers normal blood pressure?
Yeah, and those are the things they're looking at, right? So they're looking also at like, okay, well, what doses can we give to do that, right? So if you give it, if I give 5 milligrams to a healthy patient and they see no changes in their blood pressure, well, I know it's not going to be effective, right? But if I give them 10 milligrams, and so all the while they're trying to figure out what the effective dose is going to be versus what the toxic dose is going to be, right? So you're absolutely right. So those healthy people can experience side effects from the medication, whether it be due to the therapeutic action or some other action the drug has. But that's what they're trying to find. That's why it's in a small number of people. Okay. Yeah, so by the time you get into phase 3, you have thousands of people who actually have the disease state. But again, if you think about some of these side effects, maybe 1 in a million that affects people, right? And if you're only doing it in thousands of people, that's stuff you're never going to find, right? So that's going to be one of the problems with. We'll talk about that in the next clinical trial. So just to give you an example, when they're doing kind of the basic research for this, they may have anywhere between 10,000 to 25,000 kind of chemical entities they may start trialing out, right? And then they may narrow it down to 10 to 20. They start experimenting in animals and preclinical trials to see if it could be a potential candidate to use in people. Once they get that data and say, okay, this is probably safe to use in people, possibly efficacious, they'll go ahead and put it into phase 1. Okay, keep in mind that the years as they're progressing here. When you apply for an IND, you only get 20 years on that patent. Okay, and that means that includes all the trial time you have as well. So by the time a drug actually gets out on the market, you may have run through 10 to 12 years of its patent life already, and so the drug company only has like 8 years to capitalize on that patent, right? Before generics can start to come out and kind of eat into their profitability there. So again, this is a very expensive process. Okay, so anyway, so once you go through phase 1 in healthy people, then you start to give it to a small number of people who had the disease, and then finally phase 3 trials. And then you notice, once they get actual approval to put it out in the market, now you're in a phase 4 trial. So who's included in the phase 4 trial? Everybody is. If you take a drug, you're in a phase 4 trial. You didn't even know that, did you? So if you have some weird, goofy side effect that only affects you, they got to report that. And that goes back, and sometimes that's led to drugs being taken off of the market due to things that they did not realize happened until they were doing it in thousands of people. So a good example is a drug called Vioxx, which was a type of NSAID, different than ibuprofen, but basically they found that there was an increased risk of death for people who were taking that medication versus those that did not. And so because they could not realize that with only thousands of patients, they needed tens of thousands or millions of patients to take it, they were able to remove it off the market once they saw those effects. Okay, so again, sometimes it's better to use old drugs that at least have been around for forever and a day, so at least we know what the side effects are, right? So just because a drug is the new hotness doesn't necessarily mean that it's going to be the best for the patient. And again, just to show you, in 20 years is kind of that time frame. After this 20-year period, that's when drug manufacturers and other manufacturers can start making generic products, right? So that's able to bring the cost down quite a bit, but it also means that the initial manufacturer is not able to really recoup a lot of their cost yet. Okay.
So it has to be 8 years before they can make the generic. Is that what you
Well, 8 years is just like that was just kind of a wild number. So it could take longer, could be less. It just depends on how fast they can get through those trials.
Okay.
Right, and so it depends on how fast the FDA can go through and review that stuff. And there's also like money that's involved there. So companies that pay more money, sometimes they can get their stuff pushed through a little bit faster. And there's lots of kind of odd stuff that goes on there. But this explains why it's such an expensive process, because there's so many drugs that fail that never get brought to market. Right, for every one drug that makes it out, there's thousands of other chemicals that are deemed not to be appropriate or not brought to market. They're still wasting all that money. Right. So again, this is why it somewhat explains why drugs are so expensive. Certainly, there's been lots of press about people who are general bad people trying to drive up markets on kind of small niche drugs, but that's neither here nor there. Okay, so again, just to give you an example of kind of the money that goes into just millions of dollars that goes into these processes. You have to pay all the volunteers. You have to do the research and lab tests and all kinds of different things. You can see how the price rate starts to increase pretty significantly there. And again, there's no fixed duration on the phase 4 trial, so everyone that's ongoing for as long as the drug is out in the market. We have methods for reporting these adverse effects or these different problems that come about with the drug through to the FDA. And once they get enough reports about something, they say, okay, well, maybe we should reevaluate this, take it off the market, or say maybe you don't give it to these type of patients. And this is where a lot of things like black box warnings come from. You guys ever heard of those? What are black box warnings? Not those. Those are black boxes, but not the same black box warnings we're talking about here. Yeah, so they're given to drugs for potential very significant adverse side effects. Okay, so say for instance, I think a good one. So giving like antipsychotics, like sometimes when you have older patients who have dementia, sometimes they try to give antipsychotics to those patients in order to deal with that dementia. And they found increased risk of death for them. So once they saw this, they said, okay, here's a black box warning that goes on the drug labeling and says, hey, don't give this drug to these patients, okay, for risk of death or whatever the outcomes are. You can see it for anything. A lot of amphetamines used for ADHD get put a black box warning for their addictive potential. So it could be lots of different things those warnings get put on. But a lot of it comes about from both the initial clinical trials and these phase 4 trials that kind of bring some of these things to light once they're being taken by a lot of people.
Where's the line between like a black box warning and then just like taking it off the market or not?
That's a good question. Usually if it's If it's kind of death in a very small subset of patients who probably shouldn't be receiving that drug anyway, that could be something where they say, well, let's do a black box warning, right? If it's something where it's like it affects everybody, that's probably a good reason to take it off the market. And then there's going to be a lot of gray in between. And it could not even be for stuff like that. Sometimes they actually have even more restrictive programs called REMS programs. We'll talk about that eventually. But if you think about a drug called Accutane, used for acne, that's one that has very significant chance to cause birth defects in babies. And so that's one of those things where the mother has to be, or the female patient has to be on a registry, the provider has to be registered, the pharmacy has to be registered, she has to have multiple pregnancy tests to show she's not pregnant just to get the drug, right? And so that is in order to try to limit how many people actually experience those really negative side effects. Right? So lots of things we do to try to instill some degree of safety with these products. Okay, so again, assuming everyone makes it through the first 3 trials and then phase 4, again, no fixed duration, that's where we're going to be reporting a lot of those adverse effects when we get out to a larger market. The average cost that I most recently looked at was $2.6 billion, right? It's expensive, billion with a B, to bring a drug to market. So, yeah, that's why drugs cost so much in a lot of cases due to the fact they need to recuperate these kind of things. And if you think about it, like, you know, how many people do you think have hypertension? Millions of people have hypertension, right? How many people do you think get bitten by coral snakes every year? Like 35, like here in Florida, that's it. So if you think about it, like, they probably want to put their efforts into things that are going to be big blockbuster drugs that are going to have the potential to reap a lot of benefit, right? Sometimes you have niche little indications, things like, you know, envenomations or things like mitochondrial disorders where it's more difficult to get those kind of drugs out because there's not a big market for it, right? So a lot of times there's some ethical considerations for, like, you know, how do you get these medications? Sometimes they'll have what we call compassionate use, where if a patient has no other recourse, they have a really rare disease, they'll get a chance to utilize a drug even though it's not FDA approved for certain, you know, for those reasons. So you know, there's a lot of kind of interplay here and there depending on the disease state. But again, a lot of this is money driven in a lot of cases. Okay, I think I'm going to go ahead and cut it there. We'll come back next time and talk more about receptor signaling. Any questions before I let you guys go? It's been a fun 4 hours. I look forward to many more of these this semester. I'm tired. You guys have a great day.